We are live, doctor. You can start the session.
Thank you, everyone. So we at Team YOSI, so we are going ahead with our journal club. So this is the first journal club after the new team has taken over. So we had the IGO live wire before, and we are having the journal club starting with the orbit now. So Dr. Divakant sir as well as Dr. Nilesh convey their regards regarding the same. So let us share a few history of the journal club before we go to the journal club session per se. So I am Dr. Prasanna Venkatesh Ramesh. So with me you can see Dr. Ayushi here, the moderator of this session. So she was again one of the brains in drafting this wonderful orbit issue, along with Dr. Niranjan and Anujit, who helped us with all the other logistics and other work for this particular journal club issue. We have a good star lined up, starting from Dr. Taljani, Dr. Ritwija, Dr. Raguraj, Dr. Puneet will be joining us, Dr. Sindhuja, Dr. Richa, and Dr. Engai from Vietnam. So the Journal Club of YOSI was one of the brainchilds of Dr. Sonal Kalia. So she was she's our immediate past president. Started 4 years back. So the of Parish, a call to action, the USPs of it. And this is the new team, the team of 2024-2026. So the president is Dr. Devakant sir. Sonal Kalia ma'am is the immediate president. Karan is also part of it, the VP. Nilesh as secretary, Aditya and myself part of the GC. And we have a dynamic team. Most of them are part of this particular meeting as well. The executives, we have the 20 expandable executives here along with us. And the concept of YOSI Journal Club was to learn and grow. So we had divided it into 5 components, as you can see, to benefit the young ophthalmologists, the fellows, the PG third year, second year, and the first year. And again, the journal clubs assessing research literature to define a problem, specifying the question, to have a definition of the variable, selection of subjects, and the MAR IEE format. The format of the journal club was devised as presenter, mentor, moderator, research expert, and then we had the panelists. So for this meeting, we also roped in an international panelist, and also for radio diagnosis, also we have expert as well, so that we wanted to give the different dimensions of this particular disease that we are going to talk today. And Ayushi has come up with an interesting twist to start the journal club, so that it gives a new kind of a set induction before we go into the journal club. So as I told you, the MAARIE format is the one that we are following. And this was the previous team. Some of them are part of this team. Dr. Anujit, who has done a brilliant job, and he's also continuing part of this journal club as well. So thank you, Anujit, for that. And if any young ophthalmologist of YOSI is looking at it, you can also be a part of this journal club. Just drop in a mail or do send in a WhatsApp ping regarding your interest regarding the same, and we'll definitely rope you in for the next journal club. And you can see a QR code here. If you scan this QR code, you'll get all the resource materials of the previous journal clubs that YOSI has done. And again, this is the mail ID that you need to send. If any one of you is watching it in YouTube or Zoom, this is that you need to go ahead. So these were some of the activities. I'm not going into the detail. I'm rushing through. In 2021, as I told, it was a brainchild of Dr. Sonal Kalia. And we had 4 chapters in 2021, again 6 in 2022. In 2023, you can see the activities were much higher in number. And these are in 2024. We collaborated with IJO for 4 capsules. And in 2024, we had the refractive. We had the case reports with IJO. Then we had the photo essays again with IJO team. Then we had again original article with IJO team. With YOSI, we had the retinal capsule. And then last month, we had the plagiarism and the reference management with IJO team. And here we are for this particular issue today. So I would like to start off by introducing the team members of today. Dr. Ayushi. Ayushi is a clinical adjunct and chief clinical research fellow, and she's ophthalmic plastic surgery and ocular oncology at LV Prasad, Hyderabad, editor-in-chief of YOSlides, with publications and 45 plus scientific and a number of free paper awards at OPAI and OSCON an international DOS Star Award, and a well-acclaimed an orbit and oculoplasty person. With that, we have Dr. Naranjan, who's also part of the convening team. So Dr. Naranjan is doing his fellowship at Tambaram Eye Hospital, Nirmal Sir's Eye Hospital. He's also a section editor at TNOA Journal, and he's also a very vibrant part of the team. And we have Anujit Paul, who's actually doing his consultant. He's a consultant at Cataract and Vitreoretinal Services at BBI Foundation, who has also won many awards that you can see, an IGO Platinum Award, the TNOA Gold Medal, and he's also having n number of accolades as a section editor in Retina and TJOSR, and also he was an executive board member of our YOSI as well. So, and I'm also part of the team, so I'm Dr. Prasanna Venkatesh Ramesh. So, without much delay, Ayushi, can you go for the quiz that you wanted to start off?
Yeah. I hope the audience is ready. Are we also
We have
including the
around 7
sponsor on
participants. You want to go at the end owing to the participation number, or you want to go now only? We have 17 participants. It's your call.
We'll go now, and we'll also include if there are any answers on YouTube.
Okay.
If anyone, Dr. Anujit, can you look at the YouTube answers?
Yeah, no issues.
I'll just share my screen.
Yeah.
Okay, so before we move to the quiz, there is no negative marking, and it's first come, first serve. So whoever will answer the first in the chat box or on the YouTube, that score will be counted. So we'll begin with our first question. So which of the following is the most common benign orbital tumor in adulthood? Option A, cavernous venous malformation. Option B, schwannoma. Option C, cavernous hemangioma. Or D, both A and C. We'll have just 10 seconds.
So we have a couple of replies in the chat box, Ayushi. So Dr. Saida says B, Dr. Sunandini says D, and Dr. Hai Nguyen says D. So you can go ahead with the answer.
Okay. So the answer is both A and C, because cavernous hemangioma is actually an obsolete term now, which is now called as cavernous venous malformation, and it is the most common benign orbital tumor in adulthood. Let's move on to our next question. Which of the following statements is not true about orbital schwannomas? A, they usually arise from peripheral motor nerves. B, the cells usually are positive for S100 staining. C, schwannomas usually exhibit cystic degeneration. And histopathology may show Verroque bodies. We have 10 seconds.
So I have an eye on the chat box. So Dr. Raghurat sir has replied with option A, I feel, and with
Dr.
option
Kiran, would you like
you
to
get option C.
guess? Dr. Gurkin, are you there?
I think we can go ahead with the answer.
Okay. So the answer is A, because they usually arise from the sensory nerves. That was a trick question. So if your orbital schwannoma is in the superomedial quadrant near the supraorbital notch, then most likely it would be a supraorbital nerve, which would be involved, which is a sensory nerve. So the answer is A here. Going on to the next question, which of the following tumors show early brilliant contrast enhancement on MRI? A, schwannomas. B, solitary fibrous tumor. C, cavernous hemangioma or venous malformation. D, orbital lymphoma. Your time starts now.
Dr. Gurkiran has replied with option B. So we'll just wait for another 5 seconds if anyone else has a reply. So Dr. Raghurat sir and Dr. Nguyen have also replied with option B. I think we can go ahead.
Yeah, so as everyone guessed it right, it is solitary fibrous tumor. Let's move on to the next question. Which of the following is the most specific immunohistochemistry marker for SFT? Is it the nuclear positivity of STAT6, the cytoplasmic positivity of STAT6, CD34, or is it MyoD1? The time starts now.
So we have a lot of replies for option C. Dr. Newgan has replied with option B. Dr. Saida and Dr. Gurkiran have replied with option C. And Dr. Raghurat sir has replied with option A.
Yeah, so the correct answer is actually A. It is the nuclear positivity of STAT6 that we need to look at if you're suspecting SFT. As majority have replied CD34, yes, it is very commonly seen in SFT, but it can also be seen in other tumors because it's a marker of vascular endothelial cells. So STAT6 is very, very specific for SFT. The last but not the least, which of the following is not the standard of care for orbital lymphoma? And by that, I mean that which of the following is not being utilized for the orbital lymphoma? Your time starts now.
Dr. Newgan has replied with option C, and Dr. Raghurat sir has replied with option A. So we'll give it another 5 seconds so that everyone else can just reply. So I think Dr. Puneet sir has joined in. He's replied with option A as well. Dr. Saida Ruhi has replied with option C. I think we have 5-6 replies. We can have the answer, Ayushi.
Yeah, so majority have replied with boom radiotherapy, which is utilized in very rare cases. It is the ultra low dose of radiotherapy. And the answer is actually D, interferon alpha 2B, which is utilized for the lacrimal gland or conjunctival lymphomas, and it has not been yet used for well-defined orbital lymphomas. So we'll have the winners at the end of the journal club, and let's hear it from the speakers now so that we learn about the common orbital tumors. I invite Dr. Anujit to introduce our next speaker.
Yeah. Dr. Aishi, can you stop sharing the screen so I can relay her slide, her introductory slide?
Thank you so much, Dr. Ayushi. So it's great to have an all-star cast today at the Journal Club. So we can start with our presenter. It gives me great pleasure to introduce Dr. Padma Priya, who's a consultant in the Department of Orbit and Oculoplasty at Arvinda Hospital, Coimbatore. She's an ophthalmologist who has passed her MBBS from Bangalore Medical College and Research Institute, followed by her MS in ophthalmology from BJMC Pune, followed by a fellowship at the Arvinda Hospital, Coimbatore, where she now serves as a consultant as well. She has also cleared her DNB as well as the Fellowship of Academy of Eye Care Sciences, FAECS. She has a number of publications and awards to her name, some of which are including poster presentation on a case series on amniotic membrane at BJMC Pune, including an original article as in BMJ Open articles, as well as instruction courses in MOSCON, as well as TNOA. With that, Dr. Padma Priya, it gives me great pleasure to invite you.
Thank you so much, sir.
Yeah, we'll have the other introduction after the speakers.
Dr. Padma, you're muted.
Am I audible, sir? Good evening.
You're
Yes,
audible.
Thank you.
yes, sorry.
Yeah.
You can share your screen.
You can
Yeah.
start your presentation now, Dr.
Yeah.
Padma.
Good evening, all. I hope you can see my screen.
Yeah.
Yes, you can go ahead.
Hi. Good evening. I am Dr. Padma Priya. Thank you so much for the introduction, sir. And it gives me great pleasure to be presenting the journal today under the banner of YOSI. The paper we'll be presenting today is titled The Radiologic Features of Well-Circumscribed Orbital Tumors, and we have histopathology.
Have we lost her?
No, she's here.
You're muted, Dr. Padma.
Yeah, hi, am I audible? I'm sorry, I'm so sorry. I think my network crashed.
Yeah, you're audible. You can just share screen.
Do you want to send the PPT?
Yeah, this is okay, no issues. Yeah, so the paper we'll be presenting today is called The Radiological Features of Well-Circumscribed Orbital Tumors with a Histopathological Correlation, a multicentric study. This was published in Ophthalmic, Plastic and Reconstructive Surgery in the issue of July-August 2024. So the four most common tumors, orbital tumors that have been handled in this paper are the solitary fibrous tumors, schwannomas, cavernous venous malformations, and well-circumscribed orbital lymphomas. The aim of the study has been categorized as primary and secondary. The primary aim is basically to compare the imaging characteristics of the four tumors, SFT, that is solitary fibrous tumors, schwannoma, cavernous venous malformations, and the lymphomas. And the secondary aim has also been to compare the histological correlations for each of these entities and to compare them with the radiological features to make diagnosis and prognostication easier. This study was essentially a retrospective and observational study. It was multicentric, carried off in 3 centers over US and Australia. The demographic data presenting signs, symptoms, and the histopathology were taken from already existing medical records. The available radiology was assessed by a neuroradiologist who was marked to the SPE-HPE, which means it was masked to the diagnosis. The inclusion criteria were patients who had undergone excision biopsy and who had a preoperative MRI available for review. The exclusion criteria, however, had not been specified in the study. They essentially assessed the imaging characteristics, both CT and MRI. Under the CT, the location, which is coronal, conal, and axial, the bony changes, effect on the globe, and the shape of the tumor were taken into consideration. And under MRI, both T1 and T2 weighted images were characterized, homogeneity or heterogeneity, regionality, including the biphasic, regional, and the inhomogeneous nature, enhancement patterns, enhancement intensity, as well as diffusion weighted imaging and the apparent diffusion coefficient were all assessed under CT and MRI findings. Certain essential important signs were also characterized, the first of which is the target sign. As you can see in this image, it is basically a central region of hypointensity with a peripheral hyperintense rim. This is known as the target sign. The next sign is the fascicular sign, which is seen on the T1 weighted images. They are defined as the multiple small ring-like structures surrounded by a peripheral hyperintensity. This is the fascicular sign. And the cystic degeneration, which is basically hyperintense on T2, but it is isointense on T1, and they're non-enhancing on post-contrast images. Basically, cyst-like, fluid-like degeneration of the tumor itself. These 3 signs have also been described and defined in each of these tumors. Coming to the regional effect, the molding of the tumor to the globe, indentation of the globe, or no effect of the tumor on the globe. These were studied. Contrast enhancement has seemed to be quite importantly studied in the study here, both early and late. Intensity and pattern were both studied, intensity being moderate or maximal, and pattern, which is focal, diffuse, also intralesional and peripheral intensity is also studied. Now, the analysis of the study, what they did was the exploratory statistical analysis performed to identify the important radiologic features and included in a random forest model. So each of the radiological features identified were fed into something called a decision-making tree, and individual trees were all clubbed together to form a random forest model, which essentially uses the fact that a usage or a clubbing of multiple decision trees give you a more detailed or accurate diagnosis as compared to individual decision trees. Due to the absence of any numerical or parametric data, non-parametric statistical analysis was employed, and as usual it is, statistical significance was taken by p less than 0.05. 91 patients were included in the study, of which solitary fibrous tumors were 18%, schwannomas 13%, and the CVM and lymphomas, which means cavernous venous malformations as well as the lymphomas, were 49 and 26%, which is relatively higher in number, as we would expect that they are more commonly seen as well. So the demographic and the clinical presentation of the data, the table is quite large, but what we need to see here is that there is an average of each of the characteristics that have been studied and their differentiation among the 4 tumors. So what they did notice was that the age, the presence of diplopia, the presence of proptosis or pain, and the duration of symptoms all seem to be more or less insignificantly different across all the 4 tumors compared to the general or mean average of them. However, the presence of RAPD was seen to be significantly higher in solitary fibrous tumors as compared to the others, which showed statistical significance of P less than 0.01. Now we will look at each of the tumors individually to get an idea of how to diagnose them purely on radiology. Firstly, solitary fibrous tumors. So we have image A, B, and C. A is T1 weighted imaging, the B is T2 weighted imaging, and C gives you contrast enhanced features. We will look at all these tumors under all the imaging characteristics and the headings as location, T1, T2 contrast, and the T2 weight as compared to any particular histology as we would expect. Firstly, in solitary fibrous tumors, the location. Usually, they are mid-orbit or anteriorly located, which is seen more commonly in the patients that are employed in this study. Under the T1 imaging, it was seen that they are homogeneous and hypointense in more than 80% as visualized in this image here, which I have marked with the red circle. T2, they are usually heterogeneous and either iso to hyperintense, both of which are visible on image B on this slide. Contrast enhancement is maximally contrast enhancement and diffuse early contrast enhancement, as we saw in Ayushi's quiz, that SFTs have early maximal contrast enhancement in 100% of the cases. Now, essentially, for solitary fibrous tumors on HPE tend to have very high collagen content. And this is what they have found out as well, where the T2 intensity is very directly proportional to the relative proportions of the collagen fibers. The more the collagen fibers, the more the T2 hyperintensity, and the more the spindle-shaped cells, it is found out that T2 is tend to be hypointense as marked on the image. So this is a solitary fibrous tumor, homogeneous hypointense on T1, hyper on T2, and shows maximal early diffuse contrast enhancement. Schwannomas, on the other hand, so we have A and image B as well as the histology. The location tends to be temporal and intraconal because it is usually directly related to the optic nerve sheath. T1, the image is it's usually homogeneous and hypointense, which is not shown on an image here in the study. The T2 is showing heterogeneity and the target sign, which I discussed earlier, which shows a central region of hypointensity surrounded by a rim of hyperintensity. Contrast enhancement is diffuse and maximal, seen in 60 and 70% of the cases respectively on this slide. The T2 areas, now the T2 hypointensity corresponds directly to the antennae A areas. As we know in schwannomas, antennae A and antennae B are the areas that are visible. So hypointensity corresponds to the antennae A areas and the hyperintensity corresponds to areas that have melanocytic pigmentation. This is a schwannoma. Next, coming to the more common cavernous venous malformation. In the study here, they found that there is no specific localizing feature of the CVM. It was found that it is quite commonly seen in any location. That did not help us differentiate the tumor. Under T1, they tend to be homogeneous and hypointense in more than 80% of the cases they studied. Under T2, the hyperintensity is extremely typical. What is more typical and more clearly defined in this study, though, was the contrast enhancement. What they saw was progressive contrast enhancement. And why this was seen is also been defined. Basically, this correlates with the variable size of the dilated vascular channels. So wherever the feeder channels are large and have larger vascular channels, the contrast filling was obviously faster and the contrast filling was earlier as compared to as it flows into the smaller vascular channels, which showed later or less hyperintensity or contrast enhancement. Then coming to the swell circumscribed lymphomas. Location, usually they tend to be extraconal, and because orbital lymphomas have also associated frequent lacrimal gland involvement, the superotemporal quadrant was found to be involved in more than 42% of the cases. T1 shows homogeneous and hypointense. Now here we note that on T2, as opposed to the others, there is a homogeneous but hypointensity associated with well-circumscribed lymphomas in 96 and 82%, which is quite significant. A contrast enhancement again is only moderate, diffuse, and there is intralesional or septal enhancement also noted, but the enhancement is comparatively lower as compared to the other lesions that we saw. What we should remember is that lymphomas are very commonly seen to show molding, and they also tend to have an oval shape. Molding is quite commonly seen in the lymphomas as well as the solitary fibrous tumors, and they both need to be differentiated, as I will speak about further. Now, this is homogeneous, and why they have noted it to be homogeneous is that essentially the histopathology consists of sheets of large cells with high NC ratios, and these homogeneous sheets also reflect as homogeneity on the T2 weighted imaging. So we've looked at the 4 tumors, we've looked at the major radiological features, looking at typical radiology or MRI findings. So now, based on the radiological characteristics, how do we differentiate what is important and what is not? This seems to be a very extensive table, but I'll just highlight what is important for us. So the conal location was shown to be statistically significant. So the schwannomas essentially intraconal, and the lymphomas are most commonly extraconal. So this can be a helpful differentiating feature. Axial location, solitary fibrous tumors are also commonly seen in the eyelids or more anteriorly. Obviously, the other will not be visible in the eyelid. That is important to note. Lymphomas more commonly anteriorly seen, and schwannomas related to the nerves obviously more commonly posteriorly seen. So the axial location again important. The presence of the effect on the globe. Indentation is more commonly seen in cavernous venous malformations. Molding seen more commonly in lymphomas, again statistically significant. Or based on the shape, oval-shaped lymphomas are quite statistically significant. Coming to the radiological features of these. So T1 regionality, as we can see, all of them are statistically significant. All of them are homogeneous and usually hypointense in T1. T2 intensity, however, we see cavernous venous malformations are T2 hyperintense, as well as well-circumscribed lymphomas are hypointense in almost all the cases. So that is a very significant differentiating feature of lymphoma to be T2 hypointense. Early contrast enhancement patterns, almost all of them show diffuse enhancement. Coming to the early as well as the late contrast intensity, what we have to remember is that solitary fibrous tumors show maximal enhancement both early and late, and the lymphomas and cavernous venous malformations both show moderate enhancement early and late. ADC ratio, or the apparent diffusion coefficient ratio, is the most common, most important differentiating feature between the 2 tumors that show molding, that is solitary fibrous tumors and the lymphomas. But lymphomas are characteristically lower on the ADC ratio than the other tumors. So if we look in summary how to differentiate these tumors, basically if the solitary fibrous tumors, look for the location, they tend to be more anterior. Schwannomas mid-posterior, and they show a diffuse and maximal and a contrast enhancement. Cavernous venous malformation can be anywhere, but the progressive enhancement pattern is quite important. Lymphomas often extraconal, hypointense on T1 and T2, and the diffusion coefficient is showing restricted diffusion. These were the important features to look for on radiology. So what the study found is that all the lesions are essentially T1 homogeneous and hypointense. So T1 cannot obviously be used to differentiate the two. Early contrast enhancement, SFT or solitary fibrous tumors are showing maximal early enhancement. Cavernous venous malformations can show patchy early enhancement. Lymphomas have a diffusion restriction as much as half as the other lesions, and the T2 hyperintensity is absent, and the lymphomas do not tend to indent the globe. This can help you in the diagnosis of lymphomas. Histopathological correlations with the radiological features, as I have discussed and will also be highlighting further. Now, as we saw the features already, I will be highlighting those as well, and also comparing the findings of this present study with other studies. So solitary fibrous tumors, we've already found the tendency for early bright enhancement, 50% demonstrate molding, and the diffusion coefficient helps us to differentiate it with lymphoma. There is another study by Zhang et al. Which shows that SFTs tend to be more anterior, and that contrasts with our study. The schwannomas, it is seen that the presentation is extremely diverse, so the diagnosis is best made by exclusion. The location is more posterior in the orbit. They have highlighted certain other studies. That is a study by Wang et al. Which shows 5 patterns of enhancement. Most commonly the peripheral enhancement, which is obviously the target sign. But our study has shown that more common the enhancement pattern was the homogeneous enhancement. Other studies have shown superior quadrant predominance. However, the present study does not show any of these. And studies by Young et al. And other studies as well, we have seen the target and fascicular signs. So the important signs we saw quite commonly seen in schwannomas compared to the others. Cavernous venous malformation seem to be the most comprehensively described one, where the hyperintensity on T2 is typical, progressive contrast enhancement pattern extremely typical, and the reason is the varying size of the vascular channels. The well-circumscribed lymphomas, restricted diffusion, T1 and T2 hypointensity, and the uniform homogeneous signal obviously makes it quite typical. Molding is quite common, and they have highlighted other studies which show that the more aggressive the histology, they tend to indent the globe. This, however, was not a feature that was found on the present study. Coming to the limitations of the study, essentially there is no standardized imaging protocol. They have just used images that they already had available. There has been a limited ability to comment on certain features because of probably the quality of the images they had. And even though the title says histopathological review, they are not available in all the cases. So whichever they had, they have only assessed the findings that they have had available. Though the take-home message of the study is quite clear that there is a very important role of contrast enhancement, T2 intensity and homogeneity, and the apparent diffusion coefficient. Lesions share a lot of characteristics, so we cannot depend on radiology for a 100% confirmed diagnosis. However, the salient features can help us to narrow down on our diagnosis. The MARI assessment of this study now, the methods, it's an observational study with a defined sample patient size. However, the sample size is small based on the retrospective nature. The allocation is not applicable because there is no real grouping of the study. Inclusion criteria was clearly defined, but the exclusion criteria was not. Assessment of this study is that the imaging features were defined for each entity. HP correlation was clearly described for whatever images they had available. However, there is no role of any follow-up or prognosis or the accuracy of the assessment that was done later. Statistical analysis has been specified. The power and the strength of the correlation between each and the significance has been given for the radiological features, but it has not been specified about the strength of the correlation of the HPE findings. Interpretation, T2 intensity and homogeneity obviously most important. Contrast enhancement important. Imaging is not conclusive, but it can help you aid the preparedness. So the importance of this study lies in the pre-op assessment for your intra-op decision making. Why this is important? Solitary fibrous tumors should be removed without breaching the pseudocapsule because they run a high risk of recurrence and metastasis. Schwannoma, opening of the capsule allows for better debulking and intraoperative visualization. Cavernous venous malformations, your decision based on the outcome, whether you should completely resect it, whether you should go for a stereotactic radiation, depends on your diagnosis and the location to decide on how you should go ahead and manage it. Lymphomas, obviously, we do not attempt a complete resection. We do a piecemeal incision biopsy and go ahead with other modalities of management alongside. So the extrapolation of this study is that there is a further need for HP correlation as well as prognostication to be able to further decide on your prognosis and follow up your patient. And if you are able to make more clear algorithms based on the findings we have done, it may be also possible to automate such diagnosis, which will make our role much more easier and prognosis for the patient much better. Thank you for your time and patient listening.
Thank you so much, Dr. Padma, for the excellent presentation. You covered everything. Thank you so much.
Thank you all so much.
Before we move on to the series of critical appraisal by our series of speakers, we have Dr. Sindhuja today, who has 5 years of experience in orbit and oculoplasty. She is an ex-consultant at Arvind Eye Hospital and has been awarded FAI CO in 2022 She's also the section editor of the TNOA journal and has several peer-reviewed publications in index journals. She has also won multiple awards like the Best Paper Award in the Orbit at AIOS 2022. She'll be briefing us regarding the common orbital tumors of the adulthood. Over to you, Dr. Sindhuja.
Can you see my screen?
Yes, yes, Sandhu. You may need to go to the full screen.
Like, sure.
It's in full screen now. It's visible, right?
Yeah.
Yeah, okay. So thank you, Dr. Ayushi, for that intro. So I think Padma has already covered most of the related to the imaging and the HP. So I'll just give a very, very brief overview about the common orbital tumors in adults. So as we know, the tumors, it can be benign and or malignant. So it can be primary, secondary, or metastatic. So primary, as we know, it's from the orbital structures. Secondary, either from the eyeball, most commonly we know is the retinoblastoma or the choroidal melanoma, or from the paranasal sinus, and metastatic tumors from the distant side. So as you can see here, in adults, the most common primary benign tumor is cavernous hemangioma. The primary malignant is the lymphoma, and the secondary tumor most common in adults is the squamous cell carcinoma, and metastatic is carcinoma breast and carcinoma lungs. So the primary tumors, it can be further classified under from where they are arising in the orbit. It can be a developmental, vascular, adipose tissue, fibrous, osseous, mesenchymal, neural, lacrimal gland, and the lymphoproliferative. So each has the benign and the malignant types. So coming to the vascular, the most common in adults is the cavernous venous malformation, or previously known as the cavernous hemangioma. So most commonly, it's 70% it's seen in females. So it's a solitary encapsulated venous malformation. It presents as a painless proptosis. It's typically very unilateral and it has low risk of bleeding. So, and it's most commonly the location is within the muscle cone. It's just lateral to the optic nerve. So, and pregnancy has been associated with accelerated growth of a pre-existing hemangioma. So, and as we already talked about imaging, how it presents, so it is a well circumscribed homogeneous mass on CT, slightly hyperdense to muscle with mild contrast enhancement. So, the treatment for this is complete surgical excision by a lateral orbitotomy approach can be done, as it's a very well encapsulated tumor. So next common tumor in adults, the neural one is the schwannoma. So it's a peripheral nerve sheath tumor and commonly arises from the sensory nerves. So it forms 1% of orbital tumors, most commonly seen in middle-aged adults. So patients with neurofibromatosis are more likely to have the head and neck schwannoma along with the orbital involvement. And this most commonly arises from the intraorbital branches of the fifth cranial nerve. And most of these tumors are found in the superior quadrant. So in imaging in CT, it's mostly hypodense or isodense. It was also well-defined smooth orbital mass is seen. So this also can be excised completely by the exactly where the location is. Next tumor in the neural is the optic nerve sheath meningioma. This is pretty rare, but it can be seen. So this arises from the meningothelial cells of the arachnoid villi surrounding the intraorbital and the intracanalicular part of the optic nerve. So it presents as a painless progressive vision loss followed by proptosis in the end, most commonly in middle-aged women. Typically, it's unilateral, but bilateral, it's mostly seen in NF type 2. So in this, the classic Hoyt-Spencer triad is seen, that is the progressive vision loss, optic atrophy, and the optociliary shunt. So in this also imaging, as we know, there it forms the typical tram track sign and CT, and there can even be adjacent bone hyperosteosis can be noted. Management is usually observation if there is no vision loss. Otherwise, surgery is done if there is gross vision loss with gross proptosis for causing too much of cosmetic deformity. So then we come to the solitary fibrous tumor. So this is also, sorry. solitary fibrous tumor. So this is also a slow growing benign fibroblastic tumor, mostly of the mesenchymal origin. So it is previously classified as a hemangiopericytoma. So it usually arises from the pleura and the mediastinum, but orbital SFTs are very rare and it forms less than 1% of orbital tumors. So in CT, as we already saw, it also is a well circumscribed lobulated mass. It is mostly heterogeneous enhancement is seen and calcifications can be seen sometimes. So next is the lymphoma. So it ranges from a reactive benign hyperplasia to a malignant lymphoma. Coming to the ocular adnexal lymphoma or the OAL, it is a localized form of a systemic lymphoma which affects the orbit, lacrimal gland, lids, and the conjunctiva. So it forms 6 to 8% of the orbital tumors. So the most common primary OLA is the low-grade malignant extranodal marginal zone B-cell lymphoma of the mucosa-associated lymphoid tissue, that's the MALT. So it in the conjunctiva, it presents as a typical salmon patch appearance, as you can see in this picture. So radiographically, lymphomas are very difficult to distinguish between the orbital inflammatory disease. So in CT, you can see it as a well-defined homogeneous mass molding to the adjacent structures. So diagnosis is mainly by taking biopsy and treatment is by radiation. So next in the end, little bit I'll talk about the lacrimal gland tumors, as this is also a little common orbital tumors in adults. So it forms 10% of orbital space occupying lesions. It is classified as epithelial and non-epithelial. In epithelial, we have the benign and the malignant. So in benign, the common one is the pleomorphic adenoma, whereas the malignant epithelial, the common is the adenoid cystic carcinoma. And in the non-epithelial, we have the lymphoma. So a pleomorphic adenoma, it's a slow growing benign tumor. So it causes progressive facial asymmetry and it also presents with painless proptosis. It is a pseudo-capsulated, well-defined tumor. So in CT, you can see well-defined with the moderate enhancement on contrast with distinct flecks of calcification. So complete removal should be done because if there is capsule rupture, there can be high chances of recurrence is noted. So the adenoid cystic carcinoma, it's most commonly seen in middle-aged adults with a mean age of 40 years. So initial sign, it presents with proptosis with inferior dystropia. So if a patient has pain in a long-standing supratemporal lacrimal gland mass, we have to suspect an adenoid cystic carcinoma. So this pain is usually from a bone and a nerve invasion. So this nerve invasion can also present as a frontotemporal hyposthesia. So in imaging, you can see with irregular margins and bony erosions is very typical. So management is by tumor debulking followed by external beam radiation. And recently neoadjuvant chemotherapy, which is delivered by external carotid artery, can also be given to reduce the tumor size before going for surgery, as you can even avoid exenteration in such cases. So thank you. So I've just briefly explained about the common tumors.
Thank you, Dr. Sindhuja.
Thank you, Sindhu, for this wonderful summary, and thank you, Dr. Padma, for once again sharing your case. So next, we'd like to call upon one of our experts. Just getting his slides here. Yes, Dr. Punit Jain. So Dr. Punit Jain, he's a consultant in charge of ophthalmic plastic surgery and ocular oncology services, Sharp Sight Eye Hospitals, India, New Delhi based. His academic credentials are he's a gold medalist in MBBS. He did his MD in ophthalmology at the RP Center, long-term fellowship trained at LBP Hyderabad under Santosh Anawar sir. And he's also the fellow ocular oncology and ophthalmic radiation therapy at the New York Eye Care Cancer Center. And he's an executive member of YOSI. He's a section editor of Haryana Journal, DOS Times, and he has many publications and 7 book chapters, along with many awards such as the International Hero Awards, the Travel Grant Award in ICMR, ISO, to name a few. And he has been an invited faculty for many national and international conferences. So over to you, Dr. Puneet, to share the positive aspects of this article before we go to the negative aspects.
Thank you so much for that unusually long introduction. I didn't know that you want to show this presentation PPT slide. I thought this is a reference, so I just send it to you. So it's a pleasure. I thank YOSI and the YOSI General Club for inviting me to this interesting session. It's a very interesting article, and I've been given a tough choice of speaking about the positives of this article. So can I share my screen now?
Yeah, yes, Puneet, yeah.
Is my screen visible?
Yeah.
All right. Am I audible?
Yes, you can proceed, Dr. Puneet, all good.
So when it comes to the orbit as an oculoplasty and ocular oncology surgeon, it is a Pandora's box. That is no mystery. And you really don't know what you're going to find inside if you're not careful with the pre-operative evaluation of the patient. Now, radiological imaging is an indispensable part of any proptosis workup or any orbital tumor. So I shall be speaking on the positives of this article now. So the first is that the primary aim of this research paper was that it set out to give a comparison of orbital imaging, basically MRI orbit, for these four tumors. And it very beautifully describes the findings of T1 weighted image, T2 weighted image, how does the tumor behave after administration of the contrast, and also speaks about the additional diffusion coefficient as well. So I think it has been nicely tabulated in this table, and it would be very handy when you are considering these differential diagnoses. One must remember, like highlighted in the previous presentation, that the number of these tumors, especially solitary fibrous tumors and schwannomas, would be much less than the venous malformations and lymphoid tumors. The second subtle positive of this article would be that it does convey the fact that there are certain pathognomonic or named signs associated with every tumor. So one must be on the lookout for these pathognomonic signs, but if they are not present, one must not rule out the tumor as a differential diagnosis. For example, let's take the example of orbital schwannoma in this series. None of the patients had a fascicular sign positive, and less than 1/3 patients had a target sign positive. The study had about 12 schwannomas, and cystic degeneration was also noted in just one case. So if you set out for looking for a target sign and fascicular sign and you don't find it, you should not rule out a schwannoma that way. The article also very beautifully uses the random forest model. And just a bit about the model. So the most important parameter is listed at the top. And as you go along the x-axis, the farther away is the, the attribute or the parameter at, in question, the stronger is the correlation or importance of that parameter. So this, even if one remembers, this figure, then one can make a lot of sense out of these differential diagnoses. For example, a solitary fibrous tumor, the most important parameter in this study came out to be the early contrast in intensity. For a schwannoma, it was the size closely followed by the effect on the globe and the contrast in early contrast and intensity on MRI. For a cavernous venous malformation, it was the characteristic T2 hyperintensity, which is almost a telltale sign. And for an orbital lymphoma also, it was T2 intensity and effect on globe. The fourth positive would be, though the histopathological correlation is not available for the entire subset of the sample, but the little that they have shown in terms of figures, there's a beautiful histopathological correlation for an orbital tumor. So this biphasic tumor, you see one component is nicely hyperintense on T1 and hyperintense on T2, and which correlates with the increased collagen in the tumor. And the second component of the portion of the tumor is hypointense on T1 and hypointense on T2 as well, which corresponds to the spindle seed. So I've just taken an example. So this is a very nice histopathological correlation. I don't see any other positives from the article, so I'll keep it short. Thank you.
Thank you so much, Puneet sir. That was actually very well summarized and illustrated for all of us. And with that, we'll move on to the negative aspects of the article. Dr. Prasanna sir, are you sharing the screen?
Yes, sir. Yeah, I am.
So like Sir mentioned, it's a very interesting article and very lucidly explained both in the article as well as our presenters. With that, we'll move on to the negative aspects, and it gives me pleasure to invite Dr. Richa Darabwag. Dr. Richa Darab completed her basic graduation from Topiwala National Medical College and Nair Hospital in Mumbai, followed by her post-graduation from H.V. Desai Hospital in Pune, after which she cleared her ICU exams. She went on to pursue a fellowship in ophthalmic plastic surgery and ocular oncology from LB Prasad, Hyderabad, has been awarded the Fellow of All India, the FAICO in oculoplasty as well. And she has over 10 years of experience and is currently working as an oculoplasty consultant in Government Medical College, Nagpur. She is dedicated to teaching with a keen interest in research work and has won several awards during undergraduate, postgraduate, as well as at the fellowship level. And she spends her pastime singing, doing photography, and exploring new avenues in the kitchen. I really enjoyed that you put that in, ma'am. With that, I'd like to invite you to speak to us about the negative aspects of the article.
I think as Dr. Puneet told, they didn't expect us to show exactly the complete slide. But it's okay, it's a Yo forum. We'll keep it lighter.
Yeah.
Over to you, Dr. Richa.
Yeah, I hope I'm audible.
Yes, ma'am.
Yeah. Okay, so I would at the outset, good evening, everyone. I would like to thank all the office bearers for giving me this opportunity to come and be a part of this forum today. And I've been giving the extremely challenging topic of, highlighting the negative aspects of the article, of such a well-written article and, published in a peer-reviewed journal. So I am just going to discuss a few points that I felt could have been elaborated in more detail or could have been explained better. So going on to the first one, choice of lesions. One was inclusion of lymphoma. Now, lymphoma is a malignant entity. It has very typical imaging characteristics, as we all know. It is hypo on T1 and T2 and very, very homogeneous. It has that typical molding around the globe. Even the image that they have shown of lymphoma in their article, that is actually not very well defined if you compare it with the other three. They call it oval, but it's actually not oval. It's all around, going all over the orbit. So, and of course, very characteristically, it has restricted DWI and low apparent coefficients. So I have my questions about why lymphoma was specifically included. Of course, it does increase the numbers because it's the commonest malignant tumor of the orbit. So it does increase your sample size quite a bit. Second was about schwannoma. As my humble understanding is, we see it most typically superiorly and superomedially more commonly than laterally. But in their study, they specifically mentioned that they found it more laterally. So that was another dicey thing I felt. Second was why were only these three tumors apart from lymphoma included? So there are a few more well-defined tumors that are present in the orbit that could have been included. Optic nerve tumors go last in my list because, again, like lymphomas, they have very particular characteristics, and along with their clinical features, they can be diagnosed along with their radiology very, very typically. So that goes a little down in my list. But I felt if they are talking about well-defined tumors of the orbit in their title, maybe they could have included a little more. Lastly was the method of selection. They have not been clear about how they selected these cases. Was it consecutive cases of well-defined lesions in general and only these four turned up? Or was it that they looked for these four specific entities consecutively? The duration of the retrospective review has not been mentioned, neither as the criteria for sample size. So either of the two should have been mentioned. Where did they get that number 91 from? Most likely they reviewed files from a certain date, and that was it, but that has not been mentioned. Coming to the second thing, the size of the lesions. They do mention the size of the lesions in the methodology and in the latter part of the analysis, but they have failed to mention the size anywhere in that extensive table of theirs with respect to any of the tumors. And as we know, the size is responsible for various symptoms. More the size more will be the symptoms. It is also reflective of the duration of the disease. Correspondingly, degenerative changes are related to a longer duration and larger size. So that was not really clearly mentioned anywhere in the results. This table has been shown previously by the previous speakers, but I would like to highlight that size has been mentioned over here on the top list of schwannomas. So there has been no clarity in the written text as to what exactly this plot would mean with respect to any of these tumors. So that could have been explained a little better. Maybe Dr. Tarjini, who's going to give us a detailed statistical critique on this, maybe she can shed some light on this. Third one was about RAPD. Now, they have mentioned RAPD was documented more commonly in patients with SFT with a p-value of less than 0.01. Now, if you see this table where I have highlighted the RAPD seen in all the 4 cases, they have mentioned N and into bracket percentage. So in SFT, it is 4 and 80. I don't know how they came to that 80%, because if you see the total number of SFTs was 16. So 4 out of 16 is still 25%. 4 out of 91 is even a lower percentage. And 4 out of the total number of RAPD patients is also not 80%. So I don't know how they came to the conclusion of these figures. And correspondingly, I do not know how the p-value of that turned to be 0.01. Secondly, RAPD would again correlate with the size or the duration of symptoms. So maybe that could have been elaborated on. Fourth, they have already mentioned in their limitations about HPE correlation, but maybe they could have mentioned how many cases were studied. It was just mentioned that we could not evaluate all 91 cases, but in whatever has been mentioned and the diagrams that have been shown, only a single case in each entity has been mentioned. So we don't know the different findings that were there. We have such a beautiful table of all the radiological characteristics, a page-long table. So maybe a little bit of information on this HPE correlation could have been, spoken about, because finally this was a secondary objective of the paper as well. Because this is just a summary of the histopathological correlations, but this is all that has been mentioned throughout the paper, even during the results and even during the discussion about SFT having a T2 intensity higher proportion of collagen fibers, T2 hyper intensity of schwannomas related to Antony V pattern, the progressive contrast enhancement related to the large dilated vascular channels, and the homogeneous sheets, the homogeneous appearance of lymphoma related to the dense lymphocytic packing on the H&E staining. So this is all that has been mentioned. So, this should have been a summary, I believe, and, maybe an elaborate table about different kind of correlations could have been included. This I feel is optional, obviously, but since this was a retrospective study, this information would be easily available, and it could have added a little more light on the study, because finally, even in the aim of the study, and even why are we talking about all this, is to finally get to the diagnosis and get to the treatment. So whether these findings, benefit any intra findings, or if there were any surgical challenges, how was that managed, or maybe even something about the surgical outcome could have been mentioned. Last but not the least, so what is new from this paper? This is a beautiful table summarizing the entire paper, and this can be the best takeaway from the paper. But other than that, this information, if you look at it per se from each tumor point of view, is not really new. So it is known, but maybe the manner in which it has been compared and presented is something that is new, and something that is that we can all learn from. So that is it from my side. Thank you so much for your patient listening.
Thank you, Dr. Richa. Yeah. So we'll have a quick take on the article by one of our international faculties. Dr. Hain, you are there? Yeah. Yes. So from this this JC onwards, we have tried to rope in an international perspective as well. So is my screen visible?
Yes, sir, it is.
Yes. So we have all the way from Vietnam, Dr. Nguyen Tay Tu Hein. So welcome to YOSI, Dr. Hein. So Dr. Hein is MD, a PhD, surgeon in oculoplasty and reconstructive department, Vietnam National Eye Hospital. She's an excellent surgeon. She's also a lecturer in ophthalmology department, Hanoi Medical University, also a lecturer in ophthalmology department, Thai Nguyen Medicine and Pharmacy University. She has a membership in APSOPRS, and she is also a fellow from the Harvard Medical University, Lancaster course, and Kyoto Prefectural University of Medicine, Japan. And she's also an APAO 2024 LDP member. She's my batchmate. We are currently undergoing the APAO LDP together, and you can definitely share your insights on that as well, Dr. Hein. It will really benefit the young ophthalmologists from India, especially our UC members. And she's also the woman leader in Eye Health Grant, Orbis, Vancouver 2024. So despite being the time zones being very different there, thank you for taking your time. We know it's very late there. So thank you for being here with us to share your views on this article. Over to you.
Yeah. Good evening, everyone. I'm Dr. Tu Hien from Vietnam, and thank you so much for inviting me to join with your Young Ophthalmology Society. This is the second time I take part in your seminar, and I'm very impressed with how you organize and operate such activities. In my country, the treatment of eyelid tumor is still difficult problems, and particular because we are ophthalmology hospital, so the tests and drugs for the systematic treatment still insufficient, and we need to require the coordination with the cancer hospital. The disease we usually treat are similar to those in the report you have thus presented. In weak malignant tumors account for about 30% case diagnosis and treated. In most cases, we perform a biopsy and remove the tumor and then send the patient to the cancer hospital for further treatment. Therefore, to find a seminar of your very good and meaningful, although I do not specialize in eyelid tumors, I really admire and the way you organize and very large scale and thoughtful seminar, from planning the program, inviting reporter, is diverse topic as well as attracting a lot of domestic and international reporter. I joined most of invitation of the Young India Ophthalmologist Association, the previous time I attend as a speaker and now the guest. But the most time I want to observe the way you celebrate the program and learn how to you operate and maintain a group. It helped me a lot when I organize similar for residents in my country, in my hospital. Since I was just starting out, I have quite few difficulties. So I want to ask some questions. First, how long do you need to able to hold such a seminar? And the second, is your journal is belong to the government or thus belong to your club? Your club is allowed by the state or self-filed, and how long does it take to you to complete and procedure the establishing such a club? And to conclusion, I personally think that the fact that you can organize seminar like this is really extremely meaningful for the community in general, for the young ophthalmologists in particular. There is an opportunity to help the young ophthalmologist or young resident to synthesize knowledge systematically and practice to make a report logically and professional, as well as highly scientific, and congratulations. Thank you.
Thank you, Hein. Thank you for taking your time, despite the time zones and other things. So, to just answer it shortly, so we do a lot of these activities, which is all part of the curriculum that we have for our young ophthalmologists. And once or twice in a month, we keep doing this. And in introductory, that is what I also shared it. We follow the Mary format, where it really helps beginners to how to go about starting their research journey, if they are how to dissect a paper or how they want to approach their publication journey. So these are many initiatives which we have in India, and thank you once again for joining us and sharing your views as well as sharing your regards for YOSI as well. Thank you. Be that part of it, and you can also brainstorm with the other delegates as well as we go through the program as well. So yeah, thank you. Thank you, Dr. Hain, once again. And over to Ayushi. Yes,
Thank you,
Ayushi.
Dr.
Yeah.
Yes. So a very happy Teachers' Day to everyone. And on the occasion of Teachers' Day, it's my absolute honor to introduce a teacher par excellence and a great mentor, Dr. Tarjini Dave, who's a great mentor to all her fellows, including me. She's currently the Associate Director at LV Prasada Institute, Hyderabad. She heads the Ocularis Shield Laboratory at LVPI, and besides all her qualities, she's also a great innovator and has the credit of bringing orbital tissue expanders for congenital microphthalmia and anophthalmia to our country, osteo-integrated exentration prosthesis, 3D customized implant for fractures, and for the migrated orbital implants. She also has a specific interest in ptosis and aesthetics and thyroid eye disease. Welcome, Dr. Tarjini. She'll be speaking about the statistical critique of the article and also the management approach of these common orbital tumors.
Right. Thank you so much, Ayushi. I've enjoyed every part from the journal club description to the critique made by both the pro and the con speakers. Puneet and Richa, both of you were great. Richa, you made all the points that I wanted to make. So I largely have nothing left to say. But since Ayushi asked me to speak about the statistical part, what I found most exciting here was the use of the random forest plot. Maybe if one of the speakers just puts up the slide where that plot is, a little bit of understanding might be easier. I've never seen a random forest plot being used in any of the ophthalmic plastic surgery literature that I have seen until now. It was new for me. And visually, the first impression I got was, wow, there are so many factors, and just the distance of that factor from the y-axis tells you the power that that factor has in predicting whether the MRI feature is going to match the histopathology. So that's what you are seeing here on this plot. Now I wanted to make this easy. So how is a random forest plot made? So this is one of those machine learning tools that is available to you, where you can input your data and it immediately gives you an output like this. So for all those who've not used machine learning and artificial intelligence, let me tell you, it's not a one person's job. You need an entire team of machine learning experts to whom you go and explain what is it that you want out of a model, right? Say you want to predict that if I see this kind of a fundus picture with retinoblastoma, this is the outcome that I'm likely to see. Or if I see this fundus picture, this patient has a likelihood of developing stroke. Or if I see this picture of diabetic retinopathy, this patient has so and so likelihood of developing proliferative diabetic retinopathy. So those are the kinds of prediction models which are used currently. And for each of these models, the background work in developing a model has been close to decades. Therefore, a random forest plot is something that's most loved by a lot of machine learning experts. How sweet, Puneet. So they are most loved by machine learning experts because it's a very easy model which is available to you, where if you know what are the data points that you want to study for a particular outcome and you input those data points, it's going to give you information back, and that information is relatively of good accuracy, it's robust, and it's easy to use. Like you can see your visual impression here, where they've inputted several pieces of information from what is the MRIT1 feature, what is the MRIT2 feature, what's the contrast uptake like, what is the size of the lesion, what is the location of the lesion. And if you have these basic radiology attributes inputted, you are going to get an answer that, okay, this is the lesion that you are looking at. So in those terms, it's an ensemble model which does not require too much of pre-processing, and that's where its value is. Now, if it is so good, then what is the problem with the random forest model? The issue here is that a lot of it depends on the data that you're inputting, right? You've heard the term GIGO, garbage in, garbage out, right? So for example, Richa very rightly pointed out that they've mentioned size here, correct? So according to this study, what predicts schwannoma the best is the size of the lesion. But what's the size? Did you know the size? What exactly is the size? Is it, what do you mean by large size? More than 2 centimeters? That kind of referencing. So if you want to get that information from the model, you will not get that information, that what's that size cutoff that you are looking at. So that's the problem currently with this model. And that is what I feel is one of the most difficult tasks. It's treacherous to get important pieces of information out. So that would be one of the most important critiques that I wanted to make on the statistical method. Besides this, Richa has pointed out a lot of things. I think the RAPD part, Richa, was possibly them giving the number and percentage is all patients with RAPD. Of those, how many had a schwannoma, how many had a SFT, how many had a cavernous venous malformation. So if they had 20 patients with RAPD, or 4 plus 4 plus 9, so something like that, I'm not very sure again over here, and probably some clarity from their side would be helpful in terms of because this is the only statistically significant factor. You'd want to know what exactly is happening here. So those were the two parts as far as the scientific critique is concerned. Now, in my mind, right, and this is something I teach all my fellows, that when you see a well-circumscribed lesion in the orbit, you're largely thinking of a cavernous venous malformation, a schwannoma, a solitary fibrous tumor, a neurofibroma. Like Richa rightly mentioned, a lymphoma molding around the globe is not even on your list of things. It's something that's so telltale on radiology. You see that molding around the globe, you're not thinking of anything else. But amongst these well-circumscribed lesions, I would want to plan tactically preoperatively. How would I want to plan? I know, and we know from this article, that solitary fibrous tumor has brilliant contrast enhancement. It's chalky white on contrast enhancement. What does that brilliant contrast enhancement mean? It means it has so much of blood inside it. So if you're going to be dealing with a bloody, messy tumor, which you have to excise completely, otherwise it can turn malignant, you want pieces of information like, where is the feeder vessel to that tumor coming in from? Could you do a preoperative embolization of that feeder vessel? What exactly are the locations of multiple feeder vessels if that tumor has more than one feeder vessels? Why do you want to know all of these details? You want to know these details because you go around in the orbit dissecting everywhere other than the feeder vessel, freeing it from most places, cauterizing the feeder vessel, and then cryo extracting or using hand over hand or tumbling or whatever is your preferred method of delivering a tumor. You do that. If you don't have the information of where the feeder vessel is coming in, and imagine you're separating the tumor from the rest of the tissues and you end up severing one of these arterial feeders to the vessel, going and cauterizing it is going to be a absolute treacherous job within the orbit with a lot of collateral damage. So those kinds of pieces of information was what I was looking for in terms of the excitement that built up within me when I read the title of this article. But unfortunately, that was not something that came out. And I just want to end with the last line that the authors themselves make, which I found extremely profound, that in such situations, a diagnostic equipoise preoperatively and a pathologic surprise postoperatively is not uncommon. Preoperatively, even with all this knowledge, when you tomorrow go and apply this to a patient with a well-circumscribed lesion, you will not be spot on. You will still be in a situation where you might say, oh, probably it's an SFT, probably it's a schwannoma, I'm not sure. And post-operatively, you were very sure this is a purple-looking tumor. This is certainly a cavernous venous malformation. And you send it to the path and they come back to you saying, oh, it was a solitary fibrous tumor. So those kind of surprises are known in the field, and that's what makes science exciting for me. So I think I'm going to end with that. Thank you so much.
Thank you so much, ma'am. I think you summarized it really well for all of us. With that, we'll move on to Raghurat, sir. We're just waiting for the slides to be shared.
Yes, Anujay.
Yes. It gives me great pleasure to invite Dr. Raghurat Hegre, sir. He completed his MBBS and then his MS from the RIO in Kolkata. Sir, I think the slides have just disappeared.
Yeah. Sorry.
Yeah. No problem.
Yeah.
Yes. So it gives me great pleasure to invite our guest speaker, Dr. Raghurat Hegre, sir. He completed his MBBS and MS from RIO Kolkata, followed by his FAICO in oculoplastic surgery and his fellowship in orbit and ophthalmic and plastic surgery. He's the head and senior consultant of orbit and ophthalmic plastic surgery and ocular oncology at Manipal Hospitals, Bangalore. He's also the adjunct and faculty in charge of orbit ophthalmic plastic surgery and ophthalmic oncology services at the Department of Ophthalmology, Kempegowda Institute of Medical Sciences, and a senior consultant in oculoplastic service at the Dr. M.C. Modi Charitable Eye Hospital in Bangalore. His areas of interest include orbital trauma, fracture repair, ophthalmic oncology, thyroid eye disease, retinoblastoma, and facial aesthetic surgery, to name a few. He's also the director India of the Vision Mission Singapore, which is a non-profit social enterprise and aims to work at eradicating curable blindness, in developing countries around the world. With that, sir, I invite you. You can share your screen and begin your talk, sir.
Thank you very much for the kind introduction, and thanks for the invitation to be part of this journal club. I also learned a lot of things while I was listening to all the other. Yeah. So I also learned a lot of things while listening to all of your talks, and they're very beautifully done, very well critiqued and nice. And today I just know, I mean, it's almost at the end of the session, and everybody's attention spans are going on. So I'll just try to be a little bit more engaging with this, and I won't go too much into the details of how MRI, what MRI and all that. Just want to see what's new, what's the things that are keeping me excited in MRI. So no financial disclosure. So MRI basically harnesses the properties of the magnetic fields and radio frequency pulses. It generates really high resolution images of soft tissues within the orbit. It basically exploits the differences in tissue relaxation times when magnetic field is applied to the body. And MRI usually provides very excellent contrast resolution. So post contrast, we get very good images of where the tumor is, that's characteristics of the tumor, and several other characters. So it enables differentiation of the orbital tumors, and it's a relationship to the adjacent structures based on the signals that come out of it. So it's very important to get good imaging. And in MRI, the only disadvantage is that it takes the acquisition time is very high. So it takes more time to acquire images, and every new sequence that you need to take it takes more time to acquire those images. So, but otherwise, MRI is actually would be imaging of choice in most of the orbital tumors. So why and when do we, or why is the MRI important? So earlier, before the advent of such availability of MRIs and CTs, we usually used to use ultrasound, which is now almost, we don't use anything for orbital tumors at least. It's still being used for intraocular lesions, but orbital tumors we more or less not using unless we have to use for any venous lymphatic malformation to see the flow or something like that. So CTA, as we all know, is very good for these bony tumors like this sphenoid wing meningioma, very good in soft tissue and bone windows, give very good differentiation, and we can treat on the basis of this. But sometimes the CT scan don't give the full picture. So when we do an MRI, we see that there's a tumor sitting right at the middle wall of the orbit, and which is extending into the orbit. So how do we know what are the things that we have to zone in on which tumor where it is? So the main important thing would be the location. Many of these mucoceles usually start in the middle orbit. Even the squamous cell carcinomas also extend from the ethmoids to the middle orbit, and then the lacrimal gland area, it can be either benign pleomorphic adenoma or malignant adenocystic carcinoma. From again, SCC from the macrosinus can enter into the orbits of the. So location is very important. The anterior ones, which is above in front, and it's quite palpable. These are mostly seen in the suture lines, like dermoid, and lymphoma also can involve the lacrimal gland itself. So that also can come sometimes be there in the anterior part of the. But of course, lymphoma can also be in the posterior part of the orbit as well. Superiorly, it's usually as the textbook teaching is schwannoma is in superior orbital region, but as we've seen in the paper that they mentioned that it's mostly lateral, so that is a little off from the what we are traditionally taught. So this is so posterior again meningioma and glioma involving the in and around the optic nerve. And intercorneal cavernous venous cavernous venous malformation will usually be in the intercorneal space. Even again in this paper, the paper previously they mentioned that it doesn't have a localizing effect, but we most usually see them in the intercorneal space. And extracorneally, rhabdomyosarcoma, vascular tumors, many of the tumors come from the extracorneal space as well. So what are the things that I want to talk about today? So basically, the first one is the diffusion weighted imaging. So basically, what it is quantifies molecular diffusion in the body. So water molecules, the molecules within the body, they basically move like in Brownian motion. They move at random ways. So these diffusion weighted imaging basically captures that. So where there is a free movement of fluid molecules, then there is then it's the regular ones. So when it's the tissues are very densely packed, like in a tumor, it gives a diffusion restriction. That is the diffusion is restricted, so it gives a different signal. So it gives a different signal as we. So it gives a different signal when it's diffused. So a tumor usually gives a different signal, and then that's what I want to talk about is why it is important. So three terms, it's quite technical. You need to spend some time with it to understand what these are. So basically, like diffusion, I said, the regular movement of the molecules within the tissues. Diffusion restrictions, it's densely condensed, and there is a restriction of the diffusion of the molecules. So so these things sometimes give rise to artifacts. So we have to filter out the artifacts that are there. So for that we have something called the apparent diffusion coefficient (ADC) maps. So this actually correlates with the diffusion restriction, and the way it matches with the diffusion restriction we will be able to tell what kind of a tumor or a tissue or a lesion it might be. So just to give a pictorial representation, say in a stroke in the brain. So there you can see that there is a enhancement on the T2 image. So like I mean in the this is a DWI. So basically in the T2 image there is a lesion in the, you can see, which is correlating with the DWI image, and the TWI, you can see that it is enhancing on the DWI imaging. And when you see in the this thing, it is the ADC coefficient map. This is the ADC coefficient map, which is constructed by the computer after the imaging is done, and after DW imaging coefficient, I mean DW signals are there. So basically it is hypolucent. So that indicates that this is not an artifact, and this represents a infarction that is there in the stroke, and there is hypercellularity and cytotoxic cytotoxic areas there in that in the brain. So how do you apply that in the orbital tumors? This is a case of orbital lymphoma. So there's a lymphoma that you can see. I am not sure whether we can. 1 second. See if I can put I don't know. I'm not able to.
Your slides are not moving.
Yeah, I know. I mean, I'm just trying to see if I can use a pointer. Basically, it is. You can see on the left eye there is a mass that is on the abutting the globe. So that actually is the lesion. So that this is a T2 emitted image. This is a little hypolucent, which is consistent with the lymphoma. And then when we see that we have a DWI image where the same lesion is enhanced. I want to point out, but I can't at the moment. But the same lesion is enhanced on the DWI imaging, and when we do it, when we check the ADC maps, it is the apparent diffusion coefficient. So that again it is hypolucent. So that you can see that the lesion that it corresponds accurately. So this even before we go in, we have a very good idea that this is a lymphoma. So these can be used to differentiate between lymphoma and orbital inflammatory disease, or schwannoma from a schwannoma from a cavernous venous malformation. So this is again one more this is where there is a solitary fibrous tumor. We can see that there is a T1 weighted image that is seen, and then the DWI imaging that shows that there is diffusion restriction in those areas. And this is so this, before we go in, we know that this is not a cavernous venous malformation. This is a solitary fibrous tumor. So this is another thing that I have recently discovered. I mean, it is rediscovered. It's not a new technology. It's an old technology where we use coils that are available. That is surface coils on top. This is the image that you can see on the right side of the screen, where there's where we can keep those coils and improve the image resolution of the anterior parts of the from as close which are close to the surface coils. It's an old technology. It's been there for 1980s, but it's there are not many studies or literature on this cases on these use of these, and there are only, most of it is only research value, and it's not been that reported well. But I did find some papers which talk about this. So, and we have started using this in the past year or so to improve the imaging. So high resolution imaging can be obtained even if you have a 3 Tesla imaging. Also, it can still improve the image if you use surface coils on this. Basically, we use these coils which comes along with the MRI machine actually. So very high signal to noise ratio can be maintained until the orbital apex. Beyond that, it fades off. It doesn't give that much of a good resolution. So, like I said, both the 3 Tesla or 1.5 Tesla machine can be used. So this is how it is used in adult, and the above one is on a child. So you can see that there is a, so this is the regular protocol that is on the left side. On the right side, you can see the resolution is much improved. You can even see the pseudophakia as well, the artificial lens that is placed. I think all the cataract surgeons might get excited now. And just one second, yeah, sorry. So you can improve the resolution. Like if you take a sagittal section, you can even see the visualize the levator aponeurosis, the orbicularis, as well as the this thing as well. So all these tissues, the tarsal plate, all of those things can be visualized if you took the sagittal section. And you can see that in the axial sections also that the resolution on the right side is much better with the surface coils. So this is a basal cell carcinoma where we can go in, we can see how much of a penetration is there into the orbit, and here we can see that there is a abutment of the, it is gone full thickness, and there is an abutment of the tumor on the insertion of the medial rectus. But on surgery, it was found out that there was no insertion, but we can see that even before we go into the, because it's not visualized and cannot be visualized pre-op, because it's at the almost at the phonesis. It's very difficult to visualize this area. So this gives a very good resolution and improves the thing when we go deep, and we can know how much of excision, and gives us a negative, how much, whether we can get a negative margin or not, or whether we need to proceed with the exentration or not. So these it makes us gives us some information about what is the next course of action to be done. So here again, there is a dermoid cyst. Again, you can see that there is a, with the high resolution, you can see that it fades off as it's going posteriorly. If you can see that sagittal section where that's where the surface is where the coils are kept, and as it goes posteriorly, you can see that it is fading off, and then you can see that there's a clear demarcation line that is seen. So this is a case, this is sebaceous cell gland carcinoma. When we use the, it is a long-standing tumor, and we couldn't avert the eyelid. It was so thickened, so we couldn't even avert the eyelid. We tried to do it, but we couldn't see the undersurface of the eyelid. This is the maximum it could go, and it was not able to. And she had a lot of pain and thing, and her whole eye was congested. We did a we did a MRI, and so we did a surface coils and as well as a DWI imaging. So there you can see that there is improved resolution in the ones which have surface coils, which tell us how deep the tumor has gone, as well as you can see there's enhancement in the DWI as well, and that is more enhanced in the with the surface coils. So basically, that actually indicates there is extensive involvement of the ocular surface, and this histopathologically we could prove that it was a pegytoid spread. So it is, so then in this case we had to go in and do a exentration, and use of this surface coil could give us more information about it before we could even take the decision. Otherwise, we would have gone in, done a reconstruction, then waited for the congenital map biopsy to come, and then proceeded with a second procedure for the exentration. It's stuck. Okay. So artificial intelligence, machine learning, and deep learning. So it's all these terms are used interchangeably, but actually these are three different terms. So basically, just one second. So ability of the artificial intelligence, basically the ability of the machine to imitate intelligent human behavior. And machine learning is basically application of AI that allows the system to automatically learn and improve from experience. And the third one is the deep learning, basically it's application of these machine learning and uses complex algorithms, and there is a neural network that is formed, and the past and present, and it uses higher level information that is not easily apparent even for a human. So these are deep learning machines. So basically, it's all connected, but all are not the same terms. So basically, machine learning basically has data, and then past data basically learns from the past data and then predicts an output based on the present whatever you're inputting. So basically, they use the previous data to. So the machine learns with experience of getting more and more data from more and more data sets. So then finally it gives a product. But the deep learning is basically it forms different neural networks. So how we have nerves and each one communicates with the other via our brain. So they also have this computer models also have these neural networks where they use past information and then they get second degree and third degree level data. So level information and intuition and heuristics which then give us more information than what a actual average human would be able to perceive from a specific so we can apply all these principles even in radiology where we can do pattern recognition and improve the quality of the image, etc. So basically, this is basically what they use in retina. So basically, they take multiple retinas, feed it into the neural network training, and then when we put a new image of the retina, then it identifies whether this retina is healthy or it's a diseased eye. So this is already being used, and it's already people are using these things. So this same thing can be applied to in the MRI domain. So in this case, we can see on the left side of the screen is a schwannoma, and the right side of the screen is a cavernous venous malformation. These look similar on T1 weighted images. So it enhances similarly, and sometimes it's very difficult to make out whether one is the other. So in these cases, the machine learning and as well as the deep learning actually helps us in spotting the patterns in the cavernous cells. So here you can see, if you can notice, there are some small white flecks in the like hyperlucent flecks in the tumor. This is the same as the cavernous hemangioma. This is within the cavernous hemangioma. So this indicates areas of thrombosis. So that again points to the case that it might be a cavernous venous malformation. So this is also, we have written a textbook chapter in this recent announced advances in ophthalmology and optometry. Just recently, just last month, this was published. So the 3 Tesla machine is there. Basically, 1 second. 3 Tesla, it can basically better differentiate tissue because right now what we have usually is the 1.5 in most cases and 3 if we are in a very big center. But this is a 7 Tesla machine. It can better differentiate tissue planes due to the high resolution, and it can even image bone. And we can see the individual nerve bundles because the resolution is so good. Even without use of any surface coils or anything, it can be but it's less suitable for very narrow crevices and all, because there's a lot of artifacts that comes in, like in a skull base or inferior temporal lobes or the pituitary gland and internoroidal canal. There's not much information about orbital tumors in this, but this is something that we have to watch out for, whether we can, in trauma, whether we can image both the fracture as well as the optic nerve in the same imaging. So that could be one of the things that we can watch out for. And so some case examples, just overview of what all can be done. And so this is a case where the patient came with orbital tumor, diplopia actually, and then we had gone to another hospital. They had done a CT scan and told him that it's a lacrimal gland tumor and it could be a malignant cancer. But the MRI revealed that it was. You can see that there is thinning of the bone, of course, but that it's just a thinning. It's a remodeling. It's not infiltrating into the bone, as well as there is a fluid within the mass that actually indicates that this is not a lacrimal gland mass. And so this is no, and lacrimal gland is seen separately from the mass, which indicates that again, this is not a lacrimal mass, which is not so apparent in the CT scan. So that can be easily mistaken. So this is the advantages of using an MRI to differentiate the specific tumors. So skull-base tumors, again, there was a tumor at the absolute skull base. between in the sphenoid bone at the end. There is basically a lytic destructive homogeneous and enhancing soft tissue lesion, the posterolateral wall of the right orbit. So this was found to be a plasmacytoma, which was removed from the orbital side itself. So these things are easily visualized and see what are the limits of the tumor, and also we can see that the dura is not infiltrated. So these things can be seen if we have very good quality imaging. If as we go posteriorly, if the resolution reduces, then we may not be able to appreciate the finer details like the dural infiltration, etc. So this is another case where patient came with total external ophthalmoplegia and loss of vision in the left eye. And when we imaged him, we could see that there was a tumor-like mass on the lateral rectus. Initially, my suspicion was that it was a parasitic mass. Probably it was like a cysticercosis or something. So, but on DW imaging, we saw that it is enhancing, and again ADC was again reducing. So we can't predict whether it is a malignant tumor or not. So then our radiologist was telling this is a malignant tumor. So we went in, and then when we got it was adenocarcinoma. So primary adenocarcinoma of the orbit is extremely rare, and very rarely do we see, except probably in the lacrimal gland sometime. So that indicated that the tumor is coming from elsewhere. So when we did a PET CT, we saw that it is coming from the esophagus. So this is a esophageal cancer diagnosed from orbital biopsy. Thank you very much.
Thank you, Raghuram sir, for this extensive coverage of the topic. And last but not least, thank you, Rituja, for being very patient. So you're going to be our finisher, and so she's also our monthly mentor. So once again, it's an honor to introduce Dr. Rituja Thomas. She's a consultant, orbit and oculoplastic surgeon at Vision Eye Centers, New Delhi. She has completed her basic medical training at St. John's Medical College, and she has earned a DNB and fellowship in orbit, oculoplasty, lacrimal, ocular oncology, and oculofacial aesthetics from Narayana Nethralaya, Bangalore. And she has many peer-reviewed publications and book chapters, presented at multiple conferences from a city level to an international level, and won numerous awards for her papers, videos. And she's also the member of national and subspecialty societies, including the APSOPRS, and serves on the editorial board of DJO and DOS Times. So thank you, Rituja. So she's been our monthly mentor, and thank you for waiting patiently. And over to you. And we also have your presenter here, and the stage is all yours to summarize today's evening.
Thank you, Prasanna, for first of all having me. And of course, Anujit for organizing, and I don't think any of it would have been possible without Ayushi and how she's structured this whole thing, because this wasn't just a journal club. It was more like, a complete overview of orbital tumors, well circumscribed or otherwise. And although I am the last person, but I don't have anything show-stopping to say, because everybody has already, given a great overview on each of their topics. And although all of you all are good friends of mine, I was glad to interact with Dr. Padma, who is a new friend now. And she presented very well, included each and every thing in the paper, because of which everyone could put across their views, positive, negative, etc. And just a couple of things about the paper as such was that I don't think it would have been easy for them to put across certain things, like the way the histopathology in certain cases was correlated with the imaging exactly, and that kind of gives a very good idea about how you can go ahead with diagnosing things just with the radiology. And of course, it's actually a very good study for beginners to look at, because it gives each and every cardinal feature of each of these tumors. And whatever this random this forest model shows,
it's actually what everyone has gained from years of practice. So all the minor points which they've brought out to diagnose these tumors is something that we all unconsciously use in the clinics to actually come to a diagnosis. And the main point of even coming to a differential diagnosis is so that you can decide on an incision biopsy versus excision biopsy, or debulking, or as Dr. Tajani said, doing a preoperative embolization. All of these things are very important actually in clinical practice. So whether or not the study did anything path breaking, which it didn't, it was actually a nice thing for fellows to have as a kind of overview of well circumscribed tumors. And also really appreciate Dr. Tarjani for taking out time and actually explaining the statistics to us. Dr. Puneet, who looked happier during Dr. Richa's presentation, because he he didn't really like all the he wasn't too sure about his positives either, but it was good. And of course, Dr. Sindhuja for giving us that outline about tumors, and Dr. Raguraj, who gave an extremely detailed, talk on imaging, which I think I'm glad that this is being recorded, because it's required in posterity also for people to go through to learn about imaging. So all in all, a really well-rounded and educational journal club, probably more than the previous ones that I've been a part of. So thank you.
Thank you, Rituja. Before we go to an active discussion, we have Akshay Nair sir with us, another OG in the field of orbit and oculoplasty. Sir, welcome, sir. It's such an honor to have you part of this journal club. So,
it's always fun to be a part of YOSI, especially now that I'm no longer Yo. But Rituja, when you say well-rounded, I have to be here. So
yes, sir. So we made sure you are there to end like Dhoni. So over to you, sir, to have your views on this particular article and overall this particular journal club.
So I think the choice of article was very important, because I think sometimes we get drowned down in choosing articles that are obscure and go too much into details of statistics, etc. But this was something that was it's a very, very relevant topic, because more than half of the patients who walk into an oculoplastic clinic, we end up requesting imaging for them. So choosing a topic of imaging, especially MRI and orbital tumors, was very relevant. And then to have someone as erudite as Raghuraj speak on that, giving his experience as well as these cases, was perfect. So I think I don't have anything to add from a scientific perspective, but just as a third person, as a senior citizen, I enjoyed the talk because it was well-rounded. The discussion was very good.
Thank you, Akshay, sir. And any other suggestions or tips from of our elite panel speakers? Ayushi, Dr. Ayushi, Dr. Puneet, any other comments on this particular article? As a glaucoma surgeon,
I would have loved to switch places with Richa,
okay.
But I was not given that luxury, so I tried to make the best out of it. But yeah, it was a very good learning experience, especially what Rajini ma'am brought out. I think that's good. I was wondering why we don't have these plots in our studies. So I think she answered that question before I could ask that. So yeah, I think it was a great learning exercise. Imaging is always fun. Imaging is always learning, lots of learning when it comes to radiological imaging.
Being a glaucoma person, I think I speak for Anujit as well. Being a retina, I think we too learned a lot, is what I should say. I think going forward, at least identification or as like an OSCE, it was good to brush the basics again. So if we for want of time, can we have the quiz results, Anujit? We had a short quiz when we started this.
Just one more addition. If you the article that I showed in the this thing, if basically it's in the textbook. So if you want a soft copy, I can share it with whoever wants it.
So definitely, sir. All these resources will really help our young ophthalmologists going forward. Do share it in this group, sir. We'll take it.
Yeah, sure.
We'll also
It's
compile
basically
in
Akshay's baby. So
It
Akshay has
is
written
it is
that
a hard
article.
copy that's next to me.
Yeah, even I got it. So it's
we are
Akshay's baby, but we're glad to share it with you guys if it'll be helpful for you guys.
collecting a resource, sir, for the residents and the postgraduates and the fellows. So we'll definitely, with your permission, I think we'll definitely, with due credits, we'll make sure it reaches the right place.
Yes.
Anujit,
Doctor, I have a question.
Yeah.
Sorry, I connected. So you showed a patient with a ring enhancing lesion in the medial rectus muscle. The last patient that turned out to be a metastasis. Initially, you were suspecting it to be.
In the lateral rectus, correct? Yes.
So did you do another imaging for that, or was it another cut that we should look at? Because there are so many cases like that, and we are always confused between myositis versus cysticercosis, and it's
No, it's
always
the same. We didn't have to do a different imaging, the same imaging. So basically, in the imaging itself, the protocol itself has these TWI imaging as well as the other T2, T1, FSC, flare. So all of them is part of the regular protocol itself. So nowadays, most of the radiologists will have it part of their, unless they want to like have very short patient acquisition time. Usually, most of these are part of the regular protocol. So we didn't have to do anything extra as such. We didn't have to again usually most of them have it, but it's also a good idea to always be in conversation with the radiologist and send it to the same radiologist. So it would be sometimes what happens is that for the radiologist, for one orbit is just a small part of the whole body. So it's also important that not just you learn about orbit, you also keep teaching your radiologist about the orbit. So then we keep sending them orbital cases, and they get more and more better at identifying things. And of course, their radiology is of course better than any ophthalmologist because they do that for a living. But once you keep sending them these cases, they will pick up the subtle signs that you will miss as an ophthalmologist.
Ayushi, the reason I don't see it is because what we get is films that the patients bring. If you ask for the CD with the soft copy and the DICOM images, to make it very simple, when you give the patient an OCT printout, you're giving a printout, but the entire data of all the scans is in the machine. For us, we don't have in-house radiology, but that entire DWI data and whatever else you want, sequences are there in the machine. You can always get it exported on a CD.
Yes, of course.
And METs, because you asked about that case, METs is something that will not fit in any of the kind of scenarios you think. It won't be an isolated lacrimal gland mass. It won't be myositis with a diffuse muscle thickening. It will not be like a cysticercosis with a nice, circular cyst enhancing. It will be a lumpy, bumpy, irregular mass in one muscle with an intraconal extension, and you will see a small speck in one of the other extraocular muscles. The moment you see a multifocal involved image, that should ring a bell. Or as my teacher used to say, if it doesn't strike your head, you should strike your head on the wall.
Thank you so much.
So moving on to the audience quiz answers. Anujit, over to you. You can just read out the.
Thank you so much, sir. So we had this quiz right in the beginning. So for those joining us, Ayushi conducted the quiz and we had 5 questions. So a special mention to Dr. Saida Ruhi as well as Dr. Gurkiran Kaur for participating actively in the quiz. And I would also give an honorable mention to Dr. Raghurat sir as well as Dr. Puneet sir for pitching in with their answers one after the other as well. So we'll be giving certificates to all of them. And with that, we can move on towards the vote of thanks and the conclusion.
Yeah, we do have a small virtual certificate distribution as well. Yes. Akshay sir, once again, thank you for being here, sir. And we would like to have you also here to distribute the certificates. So first we have Dr. Padma. Padma, are you here?
Hi, sir. Yes, I'm here.
Yes. So Dr. Padma was our presenter. And thank you, Dr. Padma, for inciting this active discussion from your presentation. Thank you for that. And thank you, Dr. Tarjani Dave, and for being our research expert and helping us in dissecting this article inside out. And thank you once again for taking your valuable time for it. Also, we have Dr. Rituja Thomas Grover. Special shout out to her. Even during our trial, it took us a lot of time. We had a trial version for this. We had it 2 days back, 9 to 10. She and Dr. Punit were, along with Ayushi and myself, taking a lot of time in mentoring Dr. Padma. Thank you, Dr. Rituja, for being our monthly mentor. We also have Dr. Punit Jain. So Punit Jain is also taking in charge of the academics of orbit and oculoplasty for this particular term. Dr. Punit, thank you once again for being on the panel and taking the most toughest bullet, the positive aspects, and volunteering to take it, as you told during our warm-up session day before yesterday. Thank you for that once again. And of course, Dr. Sindhuja, one of the speakers who laid the stones for the journey of discussion to start over. Dr. Richa, thank you, ma'am, once again for being one of the speakers and sharing your valuable inputs. And this serves as a e-resource which goes into our archive, and it's going to be there for all the young ophthalmologists coming forward to watch this. Thank you, Dr. Hain. I think you are still with us today. Yeah, you are here. Thank you. Thank you for being here despite the time zones, and thank you for taking your time and sharing your take on this particular article and your valuable feedback and your appreciation for YOSI and its articles or its work that is being doing. Thank you for being here, Dr. Nguyen Hain. And of course, Niranjan Karthik is not able to join us today, but he helped us in compiling all the CVs from most of the speakers and panel. I think myself, Niranjan, Ayushi, we would have kept disturbing you for a long time. Anujit Paul, again, one of the core members of Journal Club. He was there in the previous team as well as in the current team. Thank you, Anujit, for being there for YOSI Journal Club always. Ayushi, again, a big round of applause to Dr. Ayushi. Ayushi, thank you for drafting such a wonderful event. I think without your ideas, it would have not been complete. Orbit is something which I also learned a lot from that today. Thank you, and thanks from behalf of myself as well. I have been given the duty to take care of the Journal Club for the next 1 or 2 years. So thank you, dear all, for supporting us, and a special round of thanks to Akshay sir. Akshay sir, thanks a lot, sir, for being there for YOSI always and chipping in with your last but not the least, the sixer, I should say, from MS Dhoni. And thank you, sir, at short notice for joining us with today's evening. And for all the YouTube viewers and the young ophthalmologists watching this particular episode, please do send in your feedback as well as your interest to participate in this YOSI Journal Club at gmail.com. We have a Google form circulating. So YOSI is for all, and you can fill in this Google Forms, and you can also be part of the Journal Club, which we would be having under various different specialities going forward. With that, I also like to thank the whole YOSI Governing Council, the YOSI executives, as well as Numerotech, who has joined us today for this particular I think they are going to continue from today onwards for all the webinars. So thank you, Numerotech, as well as to all being part of it. With that, I would like to hand over to Dr. Ayushi, who is our orbit in charge of this particular journal club. Over to you, Ayushi, to have the conclusion of this particular event before we close it. Over to Dr. Ayushi Agrawal.
Thank you, sir. Thank you for giving me this opportunity and making me a part of this team. I want to thank all the speakers for their excellent inputs. And I would just want to conclude that it's not about whether the article was good or bad. For us, it's about learning how to critically appraise the article and learning what to take home. So thank you, everyone. I think we can call it a day now.
Thank you. Thank you all. Sai sir, can we go off live? Or we can have the mandatory photo before Sai sir goes off live. The mandatory yo photo. Yes. Dr. Shazia, Dr. Sipra, if you are there. Anujit, can you take the photo if it's okay?
Yeah, as soon as my Mac stops acting up. Yeah, I think you're good. The boon and the
Yeah,
bane of
if
technology.
you do things like this, the heart and all comes, right?
Yeah, I think you can do one with the heart, yes. But
I
Anujit,
think I'll have to give a half heart so that I
okay.
can take the photo.
Yeah, this is no, Anuji, this is being very half-hearted.
Sai sir, can we go off live? Are you there? Sai sir? Anybody from Numerotech?
Just a moment, doctor. I'm doing it.
Yes. Let us know.